Good evening, everybody who are watching from India, and good afternoon to those who are watching it from the United Kingdom. Today, our guest faculty is Mr. Robbie Ray from United Kingdom. Robbie is a nationally and internationally board-certified orthopedic foot and ankle surgeon. He's a double fellowship trained in Sydney, Australia, and Toronto, Canada. Robbie was awarded the BOFAS Gold. The focus of his research is based around elective and trauma foot and ankle surgery. He's published the longest follow-up RCT of first MTP replacement versus fusion and has submitted the largest series of missed bunion corrections in the literature of the JBJS American. His RCT on forefoot offloading shows won the BOFAS poster prize in 2018, and he received a number of research grants, including a 15,000-pound grant for the investigation of PRP in plantar fasciitis. Clinically, Robbie's work focuses on elective foot and ankle surgery. He's a specialist in foot and ankle trauma and general lower limb trauma. His NHS practice was initially as a consultant at the world-renowned St. George's Hospital Major Trauma Center. He's now moved his NHS practice to King's College Hospital Foundation Trust to develop and modernize the foot and ankle service at Orpington and the surrounding region. So today it's my honor to introduce you to Mr. Robbie Ray for the 83rd live program on orthopedic principles. Over to you, Robbie.
Okay, so good evening to everybody in India. Good afternoon to everybody in the UK. If there's any problems with my sound at any time, Gopalan, please interrupt and let me know. Otherwise, I'll start working through my presentation. So today's focus is going to be on hallux valgus and other forefoot conditions such as lesser toe deformities and arthritis of the great toe. There's not a lot of evidence in forefoot, so I'm going to give you whatever evidence there is. I also want to focus on a concept called higher order thinking and give you some tips and tricks for assessment of these conditions if you're doing a clinical exam, and also give you a framework to think about so that when you're assessing these conditions, you can assess them fully and really get to the underlying diagnosis and how to manage these conditions. So the first part is about hallux valgus. I want you to understand the complex underlying pathophysiology and abnormalities in anatomy that happen in what is otherwise described as a simple bunion. I want to talk about operative algorithms, all the different procedures that are available, and why I find this a not very useful concept. I want to explain to you guys in detail how the scarf-akin osteotomy works and why this is the best operation for hallux valgus, and specifically why this is one you should know in detail for any orthopedic exams. I then also want to tell you why I don't do the scarf-akin and what the issues with this operation are. So first of all, what does the word bunion mean? Apparently the word bunion comes from the Latin bunio, which means turnip, because this deformity looks a little bit like a turnip on someone's foot, which is one of the reasons people don't like it. So we've got to think about what actually causes hallux valgus deformity. Is it ladies wearing high heels? This is what we always thought before. And when patients came to the clinic, you would tell them, this is purely down to you wearing high heels. Please stop wearing those shoes and everything will be better. However, this isn't strictly the case. This is a picture of a Aboriginal tribe, and there's been some studies done in Aboriginal tribes to show that in these non-shoe wearing populations, people still get hallux valgus deformity. And studies will show that although shoe wear does contribute to the deformity and can aid its progression over time, if you don't wear shoes, you've still got the chance, maybe 5 to 10%, of developing hallux valgus deformity. So really, the end result is that it is a genetic deformity and it runs in families. It's important when considering forefoot pathology, all foot and ankle conditions, start proximal and work your way down. You can see on the left, this is a picture of pes planovalgus. There's too many toe signs on the right, and you can see the heel is quite out. If you look at the picture on the right, you can see the effect this has on the medial part of the foot, flattening the arch and increased pressure on the big toe. And this is one of the things that can lead to a hallux valgus deformity. So it's important to check how tight the calf tendon is, what is the deformity in the first ray, what is the deformity in the foot. This is a typical X-ray of a hallux valgus deformity, and it's interesting to note that there's obviously some deformity at the metatarsophalangeal joint, as we'd expect, but is there a deformity at the tarsometatarsal joint? And if so, does the deformity at the MTP joint at the toe cause the obliquity and deformity at the TMT joint, or is it an instability at the TMT joint that causes the bunion deformity? And this is a bit of a chicken and egg situation, and as part of this presentation we'll explore how important that TMT joint is and whether it is important. It's always good to start in any orthopedic discussion with anatomy. Anatomy is the basis of the pathology we find and basis of what we do. So when we look at a foot from the plantar side, so this is looking from the bottom up, we can see that there is a large, strong muscle, the adductor hallucis, which crosses the whole foot, and tightness in this muscle can be a contributor towards hallux valgus deformity. On the opposing side, there's the abductor tendon on the medial side, and this becomes weak and elongated, and also it changes its position in hallux valgus deformity. The sesamoids move, and the long tendons move as well. If we start by looking at a normal aspect on the left, you can see that all the tendons are central and everything works in balance. As things become unbalanced, we can see that the short flexors move laterally across the foot, as does the adductor. Even the abductor, which started off as a abductor of the foot, now becomes a flexor. And the end result of all these tendon movements is that everything, including the long flexor and extensor, the short flexors, and the abductor and adductor all work to increase the deformity. So once you start getting a hallux valgus deformity, there's a high chance this will just progress with time. From a orthopedic radiological point of view, we need to know some of the basic angular measurements. The first one is the hallux valgus angle. This is an angle from the metatarsal to the proximal phalanx. Normally it's less than 15 degrees, and we can see in the second picture in deformity that it increases. And this is how you draw them up the middle of each bone. The second one to note is the intermetatarsal angle, which is an angle between the first metatarsal and the second. And again, in a deformity situation, this begins to increase. Now, as far as I can imagine, these are quite straightforward measurements. You've got a straight toe, you've got an increasingly bent toe, you've got a normal distance between the two bones, you've got increasing distance. The one that's a bit more confusing is the distal metatarsal articular angle. And this comes down to the concept of congruency. So in a normal toe, the angle of the distal metatarsal articular angle, i.e. the angle between the shaft of the metatarsal and the joint, is pretty much 90 degrees, at the most 10. In an increased distal metatarsal articular angle, then this angle can be increased to 20 degrees, 30 degrees. And here's where it gets even more confusing. And I think if we look at some examples, it will help us. So the example on the left is a normal toe with a normal distal metatarsal articular angle, DMAA. The middle picture is one with a hallux valgus deformity. Now here you can see that the distal metatarsal articular angle is still pretty much normal, but the toe is subluxed. So this is a normal DMAA, but an incongruent joint. If we look at the final picture on the right, we can see again a hallux valgus deformity, but this time there's an increased distal metatarsal articular angle, but this is a congruent joint. So how can we sort of get this right in our heads? The way I think of it is, if you have an increased DMAA and a congruent joint, like the picture on the right, usually it's a younger patient, somebody in their 20s, maybe even 30s, who's had a congenital or adolescent hallux valgus, and the joint has grown in this deformed position. In somebody that didn't have a hallux valgus deformity but develops it in their 40s or 50s, they're more likely to have a normal distal metatarsal articular angle and an incongruous joint, such as the middle picture. So again, normal and straight, the joint should be 90 degrees. Abnormal, the DMA is increased. And abnormal with a deformity, is usually congruent, whereas normal with a deformity is usually incongruent. Now, why is that important? It's because one of the most common operations for hallux valgus surgery is a simple distal correction. You cut the bone distally, shift it across. If you've got incongruent deformity, this works quite well. By pushing the metatarsal across, it straightens up on the toe. If, however, you've got a congruent deformity and an increased distal metatarsal angle, the whole unit moves as one, and you've still got a deformity. If you try and use a soft tissue correction to correct this, you end up with a incongruent straight toe, which can lead to arthritis. So it's important to, if there is an increased DMMA, to try and correct this. The next thing, when we talk about, where this is an exam level discussion, you need to know, why are you going to operate on hallux valgus? We don't operate for cosmetic reasons, we all know that. So the main reason one may operate is because of pain over the medial exostosis and around the bunion. So that is one reason, but there's two other main reasons that I think of. When I examine the foot, I want to look for these calluses under the lesser toes. If there's a callus under the second or third toe, it suggests the first ray is dysfunctional, and the patient started to get what's called metatarsalgia, pain in the ball of the foot, like they're standing on marbles. And this can only really be corrected with bunion correction surgery. And if you look at the picture on the right, this is a crossover toe, and deformity of the toes is the other main reason that I'd like to think about surgery. The deformity of the toe only gets worse as the great toe presses further and further into the foot and becomes more challenging to correct. And this can be really painful, unsightly, and makes shoe wear very difficult. So these are all the different reasons why one would operate. We're thinking about operations, we've got to think, what's our goals of surgery? We want to reduce the patient's pain, we want to make their deformity better, and we want to maintain, or even better, improve their function. Bunions are quite common, and they're common in working age people. So if we can reduce the burden of their recovery and not use casts, wires, get them going quickly, that'd be nice. And radiologically, we want to improve all the things we just talked about. The hallux valgus angle, so we've got a straight toe. The intermetatarsal angle, so the foot's not wide. The distal metatarsal articular angle, so we've got a congruent toe that points straight. And also the sesamoids. Abnormal sesamoid position suggests there's a rotational deformity. This can increase recurrence. So if we can reduce this, that would be good as well. And finally, again, we talked earlier about the instability in the first tarsal metatarsal joint. Is this an issue, and do we need to reduce this? So we've now got some indications for surgery. We've got some goals. So what should we do? The most common operation is probably a chevron osteotomy. And then there's multiple other similar operations, such as a halal osteotomy, a Mitchell's osteotomy, where the end part is wedged in to give it stability, and a Wilson's osteotomy, which is a shortening type oblique osteotomy. Then we can move on to the diaphyseal osteotomy, such as a Ludlow, where a long wedge is cut and the thing is all rotated as one, or the scarf, which is one of the most common osteotomies performed in the UK. And I'll explain why this is a good operation in a little bit. Finally, we can come to the base, or we can do a lapidus fusion if we're worried about instability in the TMT joint. So that was a lot of different operations, and that's only a very small number of the over 100 described operations. And if you take these operations all into account, you can come up with some surgical algorithms. You can look at congruency, you can look at the radiographic parameters, you can look at the instability in the TMT joint, and you can use all this to decide in your operation. If this is the philosophy that you follow, and follow a chart, you can end up doing 4, 5, 6 different operations for one condition. And all these operations have got benefits and deficiencies. They're better at correcting certain deformities and not correcting others. And it's a lot to take in. And as foot and ankle surgeons, we already do a lot of operations. As exam level trainees, you have to learn a lot of operations. What you want to do is you want to avoid an algorithm and have a type of procedure that can correct almost all of the deformities, so that you can extrapolate this to the situation that you find yourself in with a patient. So there's too many choices. I think it's important that we go back to the basics and try and figure out an operation that's going to work in our hands for all these deformities. So what are our goals? Reducing pain, maintaining function, reducing the rehab burden, getting rid of the deformity, correcting all of our radiological parameters, and finally, a reliable operation that you can do frequently, get over the learning curve, get good at, and works for most things. So what's that operation? If you're doing an exam, there's only one answer. This is Louis Baruch, and he popularized in Europe the scarf osteotomy. The scarf osteotomy, well, actually, usually comes with the Akin, so it's the scarf-akin osteotomy, is a reliable operation that works for most things. There's some very minor exclusions. One is if you've got significant painful arthritis of your big toe joint, then you might want to consider a fusion. And we'll talk about fusions at the end of this talk. The other thing is instability of the TMT joint or arthritis of the TMT joint. So I used to worry about this a lot. Examine for instability at the TMT joint, consider doing a lapidus fusion. But then I came across some information, which was a paper by Michael Coughlin looking at an osteotomy he was doing in hypermobile hallux valgus. And his conclusions were that first ray mobility was routinely reduced to a normal level without the need for an orthodesis of the TMT joint. He calls it the metatarsal cuneiform joint. Plantar gapping was not a reliable radiographic indication. And as it was improved by his surgery, I think we can say that the severe TMT instability should not be an indication. So it actually really narrows down when we can't use a scarf-akin. The scarf-akin has 4 classic steps. The first is a lateral release to bring the sesamoids down and to reduce the tightness so that we can shift the metatarsal across. The second is the eponymous scarf osteotomy. Thirdly is a medial capsular repair. And finally, an Akin osteotomy for cosmetic correction and to give us a final straight toe result at the end. The lateral release is classically done through a separate lateral approach. It's about 3 centimeters long. It's in the web space. And the first step is to go through the intermetatarsal ligament and find the sesamoid. We're looking for this sesamoid suspensory ligament and this hood. We want to avoid the collateral ligaments and just cut the sesamoid suspensory ligament and possibly the abductor tendon, depending who you ask. The idea here is by cutting that, it loosens up this side and allows the sesamoids to go back into a normal position so that once you shift your osteotomy, the bone sits between the crista. The scarf osteotomy does have some particular points to mention. The first is the blood supply. The blood supply is plantar, and it comes in at the plantar aspect of the head. If you remove all the soft tissues from here, there's a risk of devascularizing the head and causing avascular necrosis. So it's important when you do your exposure that you respect this, and you can do your proximal exposure, but leave the capsule intact just under the head where the periosteal elevator is on the picture on the left. That way it maintains the blood supply and protects the head over quite a large shift. Before you do the osteotomy, obviously you have to remove the exostosis as well. The osteotomy is from dorsal distal to plantar proximal, usually 3 mils on either end, and the end cuts are usually made at 60 degrees. This is a long scarf osteotomy. You can also make a short scarf osteotomy. The long scarf is more stable, but the short scarf does have some benefits with rotation. The plane of the osteotomy, the best way to check this is take your saw blade and put it under the bone and see the angle of the bone, because everyone's bone is different. If you cut straight across, you'd be left with a very thin superior ledge, and this is not ideal for fixation. So ideally you cut it perpendicular to the bone, and you can change this when you're experienced to give you more or less lowering, but most people would cut this directly across parallel to the bone so that you've got 50% on either edge, allowing for good fixation. The first screw is about 1 centimeter away from the joint. You want to leave that centimeter so you don't get any fractures into the edge. And deep in the metaphyseal bone of the metatarsal head, this achieves fixation. The second screw is more proximal, and this is an important point to mention, is to start on the medial half of the top ledge to protect your lateral ledge and stop this fracture and give you good stability. With these two screws, you get excellent fixation, and it can be very stable. Patients can weight bear immediately without the need for a cast. The third step is this medial capsulorrhaphy, and there's a number of ways of doing this, per string or different tightening methods. An interesting thing to keep in mind is the old abductor tendon, the one on the medial side, which has now become a flexor. This can be found, reduced, and used to strengthen your medial repair, although not everyone does this, but it's something to look out for. Finally, an akin osteotomy is performed to straighten the toe on top of your bunion correction. So why do a scarf? The scarf gives excellent correction of HVA and IMA. The IMA is corrected very well through the scarf osteotomy itself, and any final deficits in HVA can be corrected using the akin osteotomy. We talked about DMAA before, and this is an important point. By pushing the proximal part of the osteotomy, the plantar proximal part, further across, you can actually correct the DMAA, as you see in picture C. And this is what I was saying. If you look at where the proximal parts ended up, it's sometimes easier to do this using a shorter scarf, so it doesn't bash against the second metatarsal. Thirdly, you can lengthen or shorten your osteotomy by taking a larger wedge from the proximal and distal cuts, or by just separating them. And also, to correct rotation, if you're very pronated, you can take a ledge from here, and as you push it across and compress it for fixation, it will reduce the position somewhat of the sesamoids. So this is really great. So that's as much as you need to know about the scarf. It's quite a lot of information there, and that would really cover you for most exam type operations. But I don't do the scarf-akin. And Chris Coatsey published this paper, and what he found was there are multiple potential problems with the scarf, and salvage can be really difficult. But maybe that's just because he's American. When he published this paper, a lot of people said that he had seen a video, he'd drawn a diagram, he didn't do the operation properly. So maybe it's just because the Americans weren't doing the operation properly. Unfortunately, it happens here as well. So these are all real cases. Here's one that I eventually had to revise. Very well done scarf by a colleague. And you saw here that the deformity is completely recurved, both the hallux valgus and the lesser toes. Here's one that I'm not sure what they did, but it looks like the deformity wasn't corrected in the first place. And finally, this is one of the worst ones I've seen, where due to fracture of the bone through the screws, the bone's completely spun out. And this is a very difficult situation to repair. The only real option here is to wait for it to heal in some fashion and then to perform a joint fusion. So it's not a procedure without risks. There is a learning curve, and if you do it well, you can get very good results, but it can be challenging. So what's the answer if it's not the scarf? The basics are you want to reduce the pain, correct the deformity, improve function with a quick recovery, and have a low risk of complications. You want to correct all the radiographic parameters, including stabilizing the TMT joint. In my hands, I perform an operation known as a third generation percutaneous chevron, which I'll briefly explain to you. But as I said, for the exams, the scarf is probably your best option. So the principles of percutaneous surgery are make a very unstable osteotomy. This allows maximum manipulation, and you can correct all the radiographic parameters before you fix it. Leave the lateral release to the end so that the whole toe, the metatarsal unit can be manipulated as one. Once you've got reduction, use extremely stable fixation so that the reduction can be maintained and the patient can weight bear immediately and start practicing their range of movement so they don't get stiff. Avoiding soft tissue stripping so that there's low risk of infection and less adhesions and stiffness. I perform this operation using a mini C-arm, although a large X-ray can also be used. A number of small incisions are made to allow access to the bones for fixation with screws and osteotomies. To do this type of operation, very specific equipment is required, including a minimally invasive burr, a special very small knife, and special screws. The first step, a longitudinal osteotomy is made across the neck, just outside the joint. You know that if you're proximal to the sesamoid bones, you'll be extra-articular, and this allows for more movement and makes it more unstable so that you can move it better. The first thing I do is check the reduction to see how far across I can move the bone. What I want to do, we used to just do a small reduction like on the left. Now I like to try and get as big a reduction as possible, and I also like to jack the metatarsal shaft out medially, which then locks the TMT joint and really reduces that instability, which I think is a major risk of recurrence. A wire is positioned going from the base of the metatarsal right up to the lateral wall, and this is a key step to make sure that the wire enters the lateral wall of the metatarsal. This is what gives us a lot of the stability. I check that it's straight down the metatarsal on the lateral, and then once I know that position's ready, before I put that wire further, I do a reduction maneuver. Now you can see the wires there pushing the head across, the surgeon's index fingers pushing the head up to stop it subluxing plantarly or dorsally. And finally, a rotational maneuver is used to correct the sesamoids and correct the toe position. This is why we can't do the lateral release before we fix the bunion. Finally, 3-point fixation is gained with the first screw, and a second derotation screw is used. When both screws are inserted, an oblique akin osteotomy is performed, which is a closing wedge osteotomy, not fully through and through. And this is also fixed with a screw, giving a good position. Finally, a percutaneous lateral release is performed, just nipping the plantar lateral capsule. There's been some studies very recently published in the KTSAA journal showing that a percutaneous lateral release is safe, reliable, and although the lateral collateral is also cut, it gives a safer approach than doing a large open approach. You can see the fixation is completely stable and the correction is good. These are two different patients, percutaneous on the left and previous open osteotomies on the right. On the right, both patients required a prolonged time in immobilization. On the left, they could mobilize immediately and in the end had better results. So to give an example, here's a young fit lady. You can see, if you look carefully, these are congruent bunions with increased DMAA. You can see the sesamoids just poking out, showing that there's some rotation deformity. And you can see that there's an small increase in the IMA and a reasonably large increase in the HVA. After correction, you can see the sesamoids are perfectly square. You can see that the joint has been respected. It's still congruent and straight. However, the DMA has been corrected. And you can see there's now a nice space between the toes straight, and movement was good. Here's another bunion, much more severe this time, significant pronation with the toe almost sideways, a little bit of wear and tear in the joint, and significant uncoverage of the sesamoid bones. Similarly, you can see here after correction, good stable fixation, complete derotation through the metatarsal, not cheating through the akin, and correction of the sesamoid position, HVA and IMA. So to summarize, when it comes to hallux valgus surgery, know your anatomy and know your pathoanatomy. Think of what structures are abnormal and how you're going to correct these. Stick to your basics and choose a procedure that can correct your HVA, IMA, DMA, and pronation. And you can do that with a scarf. It's a good one for the exam, but it is also quite a challenging operation, and you should know its limitations. The main limitations are probably, I said, arthritis at both ends, and also significant instability because it's hard to correct this, as is rotation. All good bunion surgery is not just a case of shifting the head laterally and cutting off the lump. It's really a 3D deformity correction, and it should be treated as such with due respect. The outcomes can be really good, but surgery is challenging, and no matter what operation you do, there will be a learning curve. So make sure you're familiar with all aspects of the procedure you choose. Now I'm going to talk about lesser toe deformities, and these really fall into three categories. The first one's a hammer toe, which you can see here with flexion at the PIP joint. Then there's a mallet toe, which is most obvious in the third toe with hyperflexion of the DIP joint. And finally, there's a sort of catch-all, which is a claw toe, flexion at both the PIP joint and the DIP joint. Now, before we go into that in more detail, it's important for an exam stage to be very, very wary of the picture on the right. The picture on the left is a hammer toe. That's simple. We can talk about toe correction. The one on the right is a complex forefoot deformity. And this is the kind of patient, there's many of these still in the community, especially overseas. And you've got a patient with feet like these in your exam. The first thing you want to do is ask to have a look at their hands as well, because this is a sign of a systemic musculoskeletal condition, such as rheumatoid arthritis, seronegative arthritis, psoriatic arthropathy. You can see here the big toes dislocated, all the lesser toes are dislocated, and this patient may have significant deformity throughout, may be on medication or may not. And a lot of these patients have lived with their deformity for a long time, and possibly conservative measures may be all they require. If surgery is required, it's a much more palliative type surgery with removal of metatarsal heads, fusion surgery rather than corrective surgery. I'm not going to focus too much on that sort of deformity correction here, but it is something to keep in mind and to know a bit about. So when we look at the three common toe deformities, mallet toes, hammer toes, and claw toes, it's important to know what's happening at each joint. So in a mallet toe, there's really nothing happening at the metatarsophalangeal joint and the proximal interphalangeal joint. There's just hyperflexion at the distal interphalangeal joint. With a hammer toe, this is different. The first deformity is actually this hyperextension at the MTP joint. And that's always important to remember and to assess how bad that hyperextension is and whether there's subluxation or dislocation here before we look at the hyperflexion at the PIP joint and either neutral or extension position at the DIP joint. Claw toes similarly have hyperextension at the MTP joint, but hyperflexion at the PIP and DIP joints. Now, before we go on to the hammer and mallet toes, which are the common toe deformities, it's important, especially for your exam, to display some harder thinking if you see a claw toe, because claw toes are not simply toe deformities or forefoot deformities. Usually there's an underlying proximal condition that's causing these. Just briefly before I go on to that, not only are toe deformities in the sagittal plane, they're also in the coronal plane. So this is a medial crossover toe, and this is a valgus toe. And some of the techniques I'm going to talk to you about, it's important to correct these deformities as well, because if you only think of it in a coronal plane, then you'll never correct the deformity fully. So looking at proximal deformities, this is a complex deformity. This patient's got clawing. You can see hyperflexion at all the joints of the toe and hyperextension at the MTP joints. But this is not a simple deformity. This is possibly Charcot-Marie tooth. So this is a complex cavus deformity. And the patient will complain that the PIP joints are rubbing. And one of the simple things you may think is just to cut the extensor tendons. But you have to think, why does the patient have this hyperextension? What has caused this hyperextension of the MTP joints and curling over the toes? Now, the most common reason in cavo varus feet is actually something called extensor recruitment. So because the tib ant is weak, the extensor hallucis longus and extensor digitorum longus have become hyperactive to try to dorsiflex the ankle so the patient can mobilize without tripping over the toes. And if you just cut the extensor tendons to reduce the PIP joint deformity, you'll reduce their ability to mobilize, and actually they'll get a gait where they're tripping over their toes. So there's a number of procedures for this. One's called a Hibbs-Teno suspension, where you cut those tendons, but then you reaffix the extensor digitum longus into the midfoot. And this is a talk about toe deformity, so I'm not going to labor too much on this. But really, this is the kind of deformity you want to examine the patient's back, you want to examine the patient's neurology, you want to see what deformities are fixed, which are flexible, and you really need to consider doing a full foot correction. However, if it's just the toes of the problem, the important thing is to consider refixing the extensor tendon somewhere in the foot. Compare that to this foot, where you can see that the attitude of the foot is really normal, apart from the curled toes. And this is the kind of thing you see after a stroke, where there is equinus, and maybe you've corrected the equinus with an Achilles lengthening. However, the patient's now got agony in their toes because by stretching the back, you've made the overly tight, long flex tendons even tighter than they were before, and all the toes are curling. In this sort of situation, actually, it's fine just to cut the flexor tendons to reduce that painful spasmodic groin. But this is, again, a neurological condition and needs a bit more thought than just simply toe corrections. For these ones, you don't even have to correct the toes. Their main problem is a painful flexion, not the rubbing on the toes. So if we think of our principles of managing lesser toe deformities, we want to rule out the complex proximal pathology, such as cavus, such as stroke. We want to be sure that there's no systemic deformities, such as rheumatoid arthritis. And then we want to look at the foot carefully, look at each deformity. Is it fixed? Is it flexible? What's happening at each joint? Is there hyperextension of the MTP joint? Is it subluxar dislocated? Or when you straighten out the foot, do the deformities correct? Is it completely flexible? Assess which structures are tight, what's abnormal. And always remember, like in most orthopedics, bony corrections are more reliable than soft tissue techniques. So again, let's start with our anatomy. And here the anatomy really is quite complex. If you're studying for your exam, you'll be studying hand surgery as well. And the deeper you look at it, the more you realize the anatomy is quite similar in hands and feet. There's interosseous muscles, there's lumbrical muscles, and the interplay is actually similar in the feet and is important when you're looking at toe deformity. On this sagittal screen, one thing we can see is that the short flexor at number 9 attaches to the base of the proximal phalanx, of the middle phalanx, sorry, and the long flexor attaches to the base of the distal phalanx. The long extensor bends right over the top and attaches to the distal phalanx. We can see the plantar plate at 9 and 10, and it gives us an idea of how we can work our corrections. Now, if we think this is complex, the extensor apparatus is even more complex with intrinsic and extrinsic contributions, and also stabilizing ligaments with the extensor hood. Now, I want to simplify this for you and say the important thing here is this thing, the extensor hood. The extensor hood is just distal to the MTP joint, and if at all possible, we want to avoid damaging the extensor hood because we then lose all the interplay of interossei lumbricals and we can run into problems with our toe corrections. The classic approach to these deformities is for flexible hammer toes, a flexor tenotomy or a Girdlestone-Taylor procedure, which I'll show you, a PIP fusion for fixed deformities, flexor tenotomies for mallet toes, dip fusions for fixed mallet toes, sorry, not hammer toes. For minor to moderate MTP hyperextension, the classic operation is an extensor tendon lengthening at the MTP joint. I don't like this because it affects the hood. I'll show you another approach. And for moderate to severe hyperextension, you can do metatarsal shortening, or for a rheumatoid condition, a proximal phalanx shortening known as the Stainsby procedure. Again, I've not gone into these in detail in this presentation, but these are things to know for complex rheumatoid type deformities. So this is an example of a classic lesser toe operation. You've got a bit of a crossover toe. You've got flexible, as we can see in the second picture, PIP deformity. And so what they've done is they've gone in, they've done a wild shortening operation and also a flexor to extensor Girdlestone-Taylor procedure. If you look at G at the bottom left, they're harvesting the flexors and moving them over the top. So this seems to work on table. It's a huge dissection, top and bottom, and there's a lot of scarring and there's a lot of stiffness. So it's a large incision with lots of scarring. The soft tissue procedure doesn't really work as well as you'd hope. The flexor to extensor transfer doesn't give the strength one would think it might do, and it doesn't do a lot for the coronal plane deformities. Usually the wire's what's holding it, and then it pops back into coronal plane deformity afterwards. And you get these things called drop toes and floating toes. So these are patients that I've done revision surgery on. On the left is somebody that had a extensor tendon lengthening. You can't see the incision really clearly, but over the second, there's a large incision. The extensor was lengthened, never really regained its function. The hammer toe came back and became fixed. And also the toe was hammering on the ground, causing pain at the tip because the extensor tendon had no function. On the picture on the right, you can see that the bunions come back, and also the second toe is just sticking up in the air. I didn't have a picture sort of end on, but if I did, you'd just see that toe just sitting, floating. And they don't really have the function to bend that toe. It's painful and unsightly. So we want to avoid these things. So let's go back to our anatomy. Consider a new anatomic approach, looking at the different structures. Now, one of the main reasons you get hyperextension at the MTP joint is that once it starts, the extensor tendon no longer pulls in a straight line and starts to pull up a hill. It's not strong enough to pull up the hill beyond the PIP joint, so it really ends up becoming a strong extensor of the MTP joint, making the hammer toe deformity worse over time. As that happens, the flexors become shorter and start to pull either at the PIP joint or the DIP joint, and usually this is what causes the hyperflexion at the PIP joint, and because the long flexor gets defunctioned as well, you get that hyperextension there. So I said to you that I think bony corrections work better than soft tissue corrections, so that the mainstay of my toe work is a basal proximal phalangeal osteotomy. By taking a wedge out here, I can turn this bent toe into a more straight toe. And that works by then giving a much more straight pull to the extensor tendon and allowing it to refunction. So in flexible deformities, I'll take this wedge out and that will refunction that. I can also then cut the flexors selectively, depending on what's tight, by just releasing the short flexor from the base of the proximal phalanx, middle phalanx, or the long flexor from the distal phalanx, just under the bone. If you look at the top left of the picture, if I'm doing an extensor tenotomy, I'll perform this proximal to the MTP joint to protect that extensor hood. And there's other procedures you can perform along these lines. So my anatomical approach, again, it focuses on your thinking what the deformities are and how you're going to improve them. If you've got a flexible hammer toe, do the osteotomy at the base and possibly release the FDB tendon. If you've got a flexible mallet toe, simply do a selective release of the FDL, which will still allow flexion at the PIP joint, but will straighten out that tip. If you've got a fixed hammer toe, do a PIP fusion and add that osteotomy to correct the coronal plane deformity. Fixed mallet toes, DIP fusions. And when we look at the hyperextension at the MTP joint, if it's mild to moderate, don't do the EDL lengthening because that will defunction the toe. First of all, you can just leave the extensor tendon and just release the dorsal capsule. That will loosen up, and with taping and the other procedures, that will stop that recurring. And if you have a very, very tight EDL tendon, do it a bit more proximal, 2 or 3 centimeters more proximal, and that will just nip the EDL, leave the EDB, and will not dysfunction the entire hood apparatus. If the subluxes are dislocated, you may want to consider a metatarsal shortening procedure. Let's talk about that in a bit more detail. We talked earlier about this overload phenomenon. So if you've got overload and you've got these calluses forming in the middle of the foot, you may want to consider a shortening osteotomy in the foot, which will bring your metatarsals into alignment and get the pressure correctly distributed. The differentials when you've got metatarsalgia, first of all, is the first ray deformity. If you've got a bunion deformity, correcting that will almost certainly reduce the pain in the middle of the foot and redistribute the pressure. If you think about it, your first metatarsal is 3 or 4 times bigger than your lesser metatarsals, and it's so much bigger for a reason. It's because it's meant to take 70 to 80% of the weight when you're mobilizing through your gait cycle. If it's defunction, you're going to take a lot more weight through your lesser metatarsals and have this problem. Look out for a Morton's neuroma. If you've got a young runner or a heavier person and the pain is specifically between the 3rd and 4th and not in the other toes, a Morton's neuroma injection or excision could improve their symptoms. Forefoot overload can be due to a number of reasons. It could be excessive lesser metatarsal length, I'm not sure about that, possibly proximal tightness, possibly abnormal plantar flexion of your lesser rays, or possibly elevation of your first metatarsal. Now, out of all these conditions for forefoot overload, I would say proximal tightness is definitely common. So if you've got tight calf muscles, then you're missing your first rocker and landing hard on your metatarsals. So this is putting excessive pressure through things. And the other one I really believe in is elevation of your first metatarsal. We'll talk about this a bit when we talk about the arthritis in the first metatarsal. But if you've got arthritis here and it's defunction, then it's not really working. And this can cause pain in the metatarsals and lesser toe deformities. Excessive metatarsal length, let's talk about that. So there was a chap called Michael Maestro, and he defined Maestro's parabola. And it's a beautiful concept. to look at the approximate lengths that toes should be and metatarsals should be. And he came up with a scientific paper about the length of all the different toes and the length of the metatarsals. And he showed that the second should be possibly the longest, and then there should be a lovely parabola moving down from that with the other toes. When you think about deformity, sorry, it's a blurry picture, but if you've got a dislocated toe, part of the Maestro philosophy is shortening all the toes to the length of the most proximal dislocated one. And this is what Baruch followed when he did his scarf-akin and shortenings. And by shortening everything to this length, you can reduce all the dislocations and clinically get pretty good results. The technique's called a Weil's osteotomy. The MS point is the Maestro shortening point. And this is where, if we look at this one for the third toe, you want to shorten everything to. So what you do is you cut your Weil's and you shift it proximally, and then you fix it in position. And by shifting it to the Maestro shortening point, this should automatically reduce your dislocation. A few things about this is, if you look at the center of rotation of the metatarsal, if you do the simple cut that they've shown of this metatarsal, the problem is not only will it shift proximally, it will shift in a plantar direction. And your center of rotation will end up not just proximal, but also plantar. And this is one of the reasons, because the whole center of rotation has changed, the toe then pops up and becomes a floating toe. So the way around this is to do a double cut and take a wedge out here, and that proximalizes the metatarsal and retains the center of rotation. If you do this, then there's hopefully less of a chance of getting a floating toe. And then you fix it with one or two screws, twist-off screws in this instance. So when we look at coronal plane deformities, these can actually be corrected through the Weil's osteotomy as well. And that was the classic technique. You can see that not only is this Weil's been shortened, it's also been translated. And you translate the Weil's into the apex of the deformity, that will straighten out the whole toe. The more modern technique is what's called a plantar plate repair. So once you've cut your Weil's, before you fix it, you take some stitches, you put them into the torn plantar plate. This was a medial crossover toe. You can see the tear in the plantar plate is lateral. So by repairing that, you get a stable construct, you pull the toe back down, and in the pictures it looks lovely. In real life, it's a bit more difficult to achieve. Finally, the similar operation can be done percutaneously. And if I was to do it, this is what I would do. This is called a distal metatarsal metaphyseal osteotomy. The difference between this and a Weil's is, number one, it's extra-articular, it's oblique, cut outside the joint, and it's not fixed. You leave them unfixed, you let the patient mobilize on them, and the idea is the metatarsals find their own length, they shorten and stabilize by themselves. If you treat this a bit like a fracture with a few weeks in a walking boot, it generally helps. It's been quite painful having unfixed osteotomies like this. I don't do this very often, to be honest. However, although Maestro's parabola is an excellent artistic and scientific concept, there's no evidence that this is related to clinical outcome. And people genetically have got long toes and no symptoms, and some people have got normal parabolas and still have symptoms. All metatarsal shortening operations are associated with frequent complications. In open surgery, these are floating toes, drop toes, and stiffness. In minimally invasive surgery, it's prolonged swelling for over 6 months in many instances, and also delayed non-unions, which can be quite difficult to treat. So personally, if I've got a coronal plane deformity, I prefer to fix it using a osteotomy at the phalanx, as I discussed before. So moving on from the main lesser toes, there's bunionette deformities, and these can be classified into 4 types. The first type just has a large head, which causes a deformity. The second type is a banana-shaped metatarsal, which the deformity is more from the angle and the change in the position of the 5th toe, which you can see is underwriting here. You can have a splayed metatarsal, which causes problems with both the rubbing on the outside and also the toe curling under. And finally, you can have one which is wide and has a bump. Now, I've explained to you my ideas on simplifying things, higher order thinking, deciding what the problem is and how to correct it. So I like to think of it in just two things. The first one is the toe deformity is not too bad. There's a lump there dorsally. There's not much in the way of splaying of the fifth toe. In this case, the patient can be managed with a simple exostectomy. You remove the exostosis and it gets rid of the bump, gets rid of the patient's pain. If, however, the patient's got this plantar callus, which suggests that the fifth metatarsal is being overloaded and is either got a high IMA or is banana shaped, and the toe's deformed, you need to do something to the metatarsal. Now, how does doing something to the metatarsal correct the toe? There used to be procedures like the Butler procedure where you would flay the toe open and then tighten it all up to make it straight. But if you think about it anatomically, the issue is actually the pull of the extensor tendon. The extensor tendon to the fifth pulls in a straight line. If you've got some increased IMA or bananing in your fifth metatarsal, the extensor tendon maintains its straight length. However, because the head of the metatarsal is over here, it starts to shorten the toe and pull it into this varus position. So simply by realigning the metatarsal head into its normal position, the pull of the extensor tendon will straighten it out again. So this is why a osteotomy of some kind to straighten out the toe will correct your toe deformity also. Like most operations of this nature, I prefer to do this percutaneously, and I can do either a shaving of the bump or a reduction of the IMA. So here you can see a girl that's got a overriding toe, a bit of a bump, a bit of an increase in IMA, and simply by doing a long closing wedge osteotomy of the shaft, has corrected both the toe and the lump. So there's a number of techniques, but the philosophy is the same. Remove the bump if the bump's a problem, but correct the metatarsal deformity if the toe and the angle's a problem. So finally, let's talk about arthritis of the big toe. So patients may present and say they've got a bunion. But if you look carefully, there's a lot of toe deformity here. The deformity is actually dorsal, and there's a lump here. And this is excessive osteophyte formation on the dorsal aspect of the toe. Now, hallux rigidus is what we call arthritis, but before we get there, there's hallux limitus. And in your exam, this is a really good test to do if somebody's got pain. Check the range of motion in the metatarsal. You may find that it's okay or it's somewhat limited. And then put your thumb under the metatarsal head and check again. If when you simulate load bearing, the toe is stiff, this is early hallux rigidus or hallux limitus. And this is the condition which may throw you off because the patient may have pain in their big toe, but good movement, not much in the way of osteophytes. Or they may have lesser toe deformity, metatarsalgia, and no bunion deformity. When you do this, you realize that because this toe is stiff when they're walking, there's another way of testing it, using your hand instead of your finger. You can see that actually because this is tight, when they're walking, it's putting too much pressure on the lesser metatarsal and causing deformity. A normal toe moves well. Hallux limitus only is restricted on weight bearing, and hallux rigidus is limited and has deformity. For early hallux limitus, a nice insole, this is a Morton's extension insole. We haven't talked a lot about insoles, but in foot and ankle for the exam especially, it's worth knowing about the basic insoles, your flat foot insoles, cavus insoles, and this one, which is a Morton's extension. Morton's extension, although it's named the same as Morton's neuroma, is specifically this insole, which reduces stiffness, and which allows for a stiff MTP joint and offloads the MTP joint. So this one I would use if the pain was in the great toe, whereas if the pain wasn't in the great toe, but more in the lesser metatarsal, I'd use a dome insert or something like a cutout for the metatarsals to allow for more pressure to go through it. It depends on what the patient's symptoms are. Like all things in orthopedics, there's a grading system. This is the Coughlin sureness grading system. I'm not a big fan of grading systems unless there's something useful to be gained from it. So from this one, I'll tell you that basically, no matter how bad the stiffness and pain is, as long as there's no pain in the mid-ranges of motion, a removal of the excessive bone from the top, a chylectomy, is usually sufficient. If there's pain in mid-range, something more is required. Coughlin sureness suggests a fusion, however, there are other options. If you look at an X-ray, you can see here's the chylus. There's excessive bone at the top of both bones. So an open or percutaneous calectomy, removing this excessive bone and checking that you've got range of movement after this, can usually improve symptoms significantly. You ideally want to remove around 20 to 30% of the dorsal head and make sure there's good movement. I wouldn't want to remove any more of the head than 20 to 30%. This is quite nice for me. If I still don't have the movement, you can do what's called a Moberg osteotomy, very similar to an Akin, but a dorsal closing wedge rather than a medial closing wedge, and this can give you the movement. Now, I did say that in grade 4, you may want to consider doing a fusion. However, I saw this paper from a colleague of mine, Julie Coles-Gatsoulis and Matt Sullivan, and I was very interested that if there's a long metatarsal, whether a shortening of the first ray can work to just decompress the joint. And that's why I did in this chap, who, as you can see, doesn't have a particularly short first metatarsal, but extreme arthritis here, no joint space, lots of pain. He was an active guy, he works in air conditioning, and he didn't want much time off his feet. So I shortened him a little bit and did a Moberg osteotomy and a Wiles and dorsal calectomy. And because of COVID, I missed him in the clinic. My colleague saw him, and at 6 weeks after his operation, he was able to mobilize 7 flights of stairs and get back to work, managing 2 miles of walking a day. So I'm a fan of this operation, but it's not, there's only very little evidence for this just now. This early results in 2018, so it's not really a standard procedure, but something to keep in mind. So should we do a fusion or a replacement? This is Leighton Hewitt. He was an Australian tennis player who started to get significant pain in his first metatarsal joint. And in around, I think it was probably 2013 or 14, he had basically gone to the end of this, and one of the consultants I did my fellowship with ended up fusing his big toe. The following year, he was Australia's #1 tennis player again. So fusions are successful, they're reliable, and you can have extremely good function. Obviously, fusing your big toe won't make you Australia's greatest tennis player, but if you're already a good tennis player, you can get back to this function. And I think I did put this in my blurb that I was part of the group that published the longest term follow-up of arthrodesis versus orthoplasty. And what we found in our series at 15 years was that, orthodesis outperformed orthoplasty. Patients had similar outcomes. However, if an orthoplasty failed, it was catastrophic. Salvage was technically difficult with complications and poor outcome, whereas fusions generally did well. So for that reason, I would suggest that you avoid getting into too much detail about arthroplasty. If it does come up in exams, you can quote my paper for that reason, or you can quote the Cartiva trials, which is the one on the right, which have shown good results out to 5 years, but really only in Tim Daniels' designer series. The independent series are showing less good results, and also silicone orthoplasty, which has been shown in the UK to have good results out to the long term, but only from the Wrightington series. So again, I wouldn't focus on too much on these. I'm not going to go into more details about how to do these operations. I think finally, I will talk about how to do a MTP fusion because it's important and may come up in the exam. First thing when you're examining these patients, again, higher order thinking, the MTP joints can be stiff, but is there a hyperextension of the IP joint? When you've had arthritis for a long time, possibly your IP joint becomes hyperextensible, and this is protective because of the stiff toe, and means that if you do fuse the MTP joint, then the patient can still rely on their IP joint function to allow them to propel. So the position is not as exacting if they have got IP joint hyperextension. So you plan your operation. The easiest way to prepare your joints is to use these cup and ball reamers that give you perfectly round surfaces to attach your joints onto, or the older style method is flat cuts. Flat cuts shorten and give you better ability to correct. So if you're doing significant deformities such as rheumatoid, a flat cut may be more sensible. Before you finally position your plate like here, one thing to remember is the position of the foot. Everyone's foot's in a different position depending on cavus, planus, and where they sit. So you really want to test your foot position on a foot plate before you fuse it. And you really want the big toe joint to be just off the flat. You definitely don't want it plantar flex because then they'll trip over it when they're walking. And you don't want it sticking up in the air. It's a really careful discussion to have with your patient in clinic, what kind of shoes they want to wear and where you want to position the toe. And even then, you're never going to be exact in surgery. So usually the position is about 10 degrees of dorsiflexion, 10 degrees of valgus. That gives you a normal looking toe that you can wear a small heel of 1.5 inches or and flat shoes quite comfortably. There's a number of ways of fusing it: screws, cross screws, staples, and screws and locking plates. A screw and a locking plate is probably the most common method now. And the best thing about this method is it's extremely stable and allows the patient to weight bear immediately. The important thing is to compress the joint first before you put the plate on. That's something for all fusion operations. Decorticate carefully, make sure there's no cartilage. It's important to remember that cartilage's job is to stop joints fusing. So if you've got any cartilage, you're likely to get non-union. Just take all the cartilage off, compress it, and then fix it in some method. Don't rely on the angle of the plate, whether it's 0, 5 degrees, 10 degrees. Check it on a foot plate and make sure that you're happy with the position before you fuse it. So those are all the technical aspects of that. So finally, this is a summary of the whole talk, really. Forefoot is most likely in your exams, I think, to either come from a discussion or a short case. Especially out of the UK, there'll be a lot of older patients with rheumatoid type deformities, or people coming through the clinics with minor deformities that are happy to come for a clinical exam, and they're good for clinical assessments, checking joints, checking proximal tightness, checking cavus and planus aspects of feet. Always think of the underlying conditions. If somebody's got clawing of their toes, is this because they've got cavus and they've got extensor recruitment? Is this somebody that's had a stroke and everything's flexing and tight? Or is this a systemic condition such as rheumatoid or psoriatic arthropathy? We have to check the other joints of the body, such as the joints in the hand, and be very, very focused on function rather than on walking and correcting deformities. Examine the proximal joints, consider their effects. And just remember that many forefoot conditions only cause minor symptoms. So always trial conservative measures, whether it's just giving the patient advice on shoe wear, little toe sleeves, or dome inserts and insoles, rather than going straight into surgery. Because the surgical talk, I focused quite heavily on surgery, but in your exam, always bring up, has the patient tried conservative measures? These are my preferred conservative measures before I move to surgery. And finally, if you are going towards surgery, think of it anatomically and correct the deformities in all planes to get the best results. Make sure that you understand your operations and your techniques and work through your learning curves, and try and focus on a small number of procedures that can give you good results rather than trying something new every time, which is always a risk in foot surgery. So that's my talk, and I'm done now. It's a lot of information, I'm sorry, but I'm happy to take some questions now.
Thank you so much, Robbie. It was lovely listening to you, and really appreciate the time and effort you have taken for this talk. I know it's a lot of material. As well as benefit, I can't imagine the number of people who are going to get benefit from this talk. You don't even need to go for a 4-foot course hereafter. Thank you, Robbie, once again. But we have a few questions that have come up. Yeah. One of it is, can you explain why does this, because scarf osteotomy is something that's extremely popular in the UK. Can you explain in a, you explained it, of course, but can you explain once more? Because a couple of guys want to really know why this scarf, you're not very happy with it.
Okay, so the history of the scarf is, before the mid-90s, most orthopedic surgeons just did a little bit of forefoot surgery on the side and did mainly distal osteotomies. I showed you some of those, Mitchell's, Wilson's. So when the scarf concept came from, actually from Wiles Senior in America, he came up with the idea, brought it to Europe and popularized it. And the benefits of the scarf are all the things I mentioned. You can correct large and small deformities. You can correct the DMAA by changing it. You can correct rotation. And I trained on scarf in the UK. That was what I did as a registrar. And it was a challenge, and I tried to learn the intricacies of it. And when I went in fellowship, I learned this other operation I discussed. And I found that by doing the operation under X-ray, by leaving the lateral structures tight and focusing on correcting in a fully three-dimensional manner, which is the big things that are hard to correct with the scarf, honestly, are the DMAA. That shift of the proximal more than distal is difficult to do and difficult to judge. And rotation is very difficult. taking that medial ledge to correct the sesamoid position can lead to sandwiching and troughing of the entire structure. And if you ask a lot of surgeons, they'll tell you that they correct rotation through the akin. They cut the akin completely and just derotate the toe there, or try to over tighten the medial capsule to get a correction. And when you do those sort of cheats, it looks okay on table, but that's when you get recurrence of deformity, I think. So I found that with this percutaneous method, although the incisions are smaller, it's actually a bigger operation and gives a better correction. And although there's a huge learning curve with all these operations, I found that was better for me. But so it depends if you're asking on a surgical technical philosophy. I've hopefully explained why I think that's a better operation. But from an exam point of view, you really want to have something that's well known, well recognized, and that you can then discuss, oh, if I was doing a scarf, maybe I would move the proximal part more, that's how I'd correct this, or I'll take a medial ledge and really make sure that I've corrected the sesamoids in my picture. So I would say that the scarf is still your bread and butter operation. And I guess it's also use that Michael Coughlin paper if you want, to avoid having to get into discussion about TMT instability and lapidus, because it is a bit esoteric, gets a bit complicated. And you can say, oh, what do you think about instability? You say, well, I like to fully correct my deformity. That does correct the instability, so I don't have to worry about that. And you can do that again with the scarf or with other operations. So that's why I personally, I don't have the scarf is a very good operation, but there's a long learning curve and it's challenged to get it right. And you do have those complications. They're all ones I've seen in 2 years of practice. So although when you see studies, they say, oh, look, very, very good results, there are some real problems with it, which is what I find.
Thank you for that. The other question that has come up is, what are the long-term outcomes of a MTP joint replacement?
What are the long-term outcomes of an MTP joint replacement? Okay, so MTP joint replacements, there's a number of different types of replacements. There's total joint orthoplasty, which can be metal or ceramic. My long-term paper was based on a metal total joint replacement. And that's when we published it 2-3 years ago, it was one of very few randomized control trials and the only one with that kind of follow-up. The results were basically, the ones that successful were as good as an orthodesis, right? That's the first point. If it's successful, it has failed, they were just as good, but they were still very stiff. They were stiff like a fusion, but they were quite happy. If it failed and lysed over time and need to be revised, they had a very poor outcome. The other types, there's hemiarthroplasties of either the phalanx or the head, and it's a similar sort of thing with those, that they have reasonable results unless they fail, and then they have poorer results than a joint fusion. And the newest one is this one called Cartiva. Cartiva is a polymer gel that you put into the head. And 3-4 years ago, it was everywhere. Everyone was talking about Cartiva. Tim Daniels and my colleague at George's, Dom Nielsen, was part of that series. They showed really good results. And everyone was saying, this is the new thing. We won't be doing fusions anymore. We'll do this. But then independent series have not managed to have those same results. And when you do your studying for your exams, that's something you want to keep in mind, the difference between a designer series and an independent series. The same with a hip replacement or a new type of locking plate. If the person that invented it always tends to have better results than external people. And you want to look at external results of something before you bring it into your practice, because you can say, well, I saw this one paper that showed this was really good and now I'm having problems. And it's just worth keeping note of that. So generally, I think if you quoting that long-term study saying there's not a lot of difference, but there's problems with joint replacements, and just having a really good technique for doing a fusion will get you through your exams quite well. You can mention Cartiva and mention the study showing that it's interesting, but there's not enough independent evidence that it's really successful yet.
And Cartiva is something that we use for the CMC joint arthritis as well, isn't it?
I think that's the thing. The evidence started in the MTP joint, but as foot and ankle surgeons, we use it for Freiberg's disease. Freiberg's disease is avascular necrosis of your second metatarsal. So people have used it for that. And probably people have used it for other small joint arthroplasty as well. I don't know about the literature for CMC joint, but I wouldn't be surprised. It will
I've
work
seen
well.
from the Taft group in the UK that they're doing the hand CMC joint arthritis using the CAR-T work.
Yeah, the CMC joint's another joint that's quite forgiving, actually. You know, there was a study of CMC between just excision of trapezium and this whole tendon reconstruction. And although the tendon reconstruction was much more complex, filled the space and everything, there was no difference in their thumb position and function afterwards. So it's quite forgiving. So probably it works quite well. You know, all the studies in CMC are based around trying to avoid a shortened adducted thumb. But you know, the patient population is usually a very elderly, low functioning population. So for most people, a simple trapeziectomy is probably fine. But you're working on the, you know, the young sportsman that's had trauma or something, maybe they need something a bit more. So yeah, I don't know the evidence, but the Cartiva does have some promising results. We just probably need to wait before we bring it into our general practice.
An MTP joint is not a weight-bearing joint, but what do you think are the most important functions of the MTP joint other than the range of motion?
Yeah, so I think it's got a very important function in stabilizing on toe off. So as you're toeing off, you know, your entire body weight for a split second goes through that MTP joint. So the peroneus longus contracts, the FHL contracts, everything sort of has a sort of concentric force to keep you stable so that as you're rolling over your big toe. And that's what I was saying, interestingly, the early thing, hallux limitus, which you can do that test to check if the big toe is functioning or tight. If you've got a problem there, a lot of people start to roll over onto the lateral raise and overload their lesser toes. That's when you get metatarsalgia, you start to get hammer toes, mallet toes, and deformity there. Like I said in my talk, if you look at an x-ray, there's a reason the first metatarsal is so much bigger than the other ones. Because although you don't walk on your metatarsophalangeal joint, you do roll over it with every step. So if you're walking 10,000 steps a day, if you're jogging, running a marathon, the amount of times that you load through, so it probably doesn't load huge weights for a long time, but it loads very frequently, quite a reasonable load. So that's where it gets overloaded. So I think that's its main function, stabilizing you over that toe off period. That's what I would.
Thank you, Robbie. That's all the questions we have for today's program. Thank you so much for being with us. This exhaustive, comprehensive, and a complete talk on Forefoot. Thank you so much for being with us, and we look forward for really more stuff from your side because the content is awesome.
Thank you very much. Appreciate it.
Thank you.
For the people that are watching, or if anybody watches it later, if you have any feedback on the talk, anything you think I need to change to make it more specific or change anything, let me know, and I will amend them in the future. Thank you very much.
Thank you so much.
Appreciate it. Bye now.
Bye.